Pomeriggio a tutti quanti, benvenuti al terzo pomeriggio dell'anno del Cardiocentro. Il titolo è veramente molto simpatico ed è un grande dispiacere presentare questo titolo senza l'ideatore, il pensatore del titolo, che è il professor Pedrazzini. Il titolo è Minoca Inoca. La componente Minoca non è listata ma è implicita nella prima definizione, il Sarchiapone della cardiologia moderna. Come molti di noi, il sottoscritto e anche il mio comoderatore, il professor Enrico Ferrari, non sapevamo cosa fosse questo Sarchiapone e quindi partiremo molto volentieri con un video a beneficio dei molti quali non sanno di che cosa parliamo. Bene, grazie mille, grazie anche per la vostra attenzione, qualche minuto investito bene a capire che cos'è il Sarchiapone. Adesso abbiamo fortunatamente tutto il pomeriggio per capire cos'è il Minoca Inoca ed è con grande piacere che do la parola al comoderatore professor Ferrari per introdurre il primo speaker.
Grazie mille Marco, benvenuti a tutti, buon pomeriggio. Dovrebbe essere in collegamento con noi da Bologna la dottoressa Edina Cenco,
Sì, buon pomeriggio.
bene, è connessa, fellow all'Università di Bologna e interessata nelle ricerche della fisiopatologia e nelle differenze dell'ischemia del cuore nel sex and gender, nella stratificazione del rischio, nelle malattie coronariche non ostruttive e negli spasmi coronarici e nella microcircolazione coronarica. Ha avuto in molte occasioni, ha fatto parte di progetti di ricerche cliniche molto importanti ed è anche il chairperson dell'ESC per il working group sulle patofisiologie coronariche e della microcircolazione. Quindi darei volentieri la parola alla dottoressa per introdurci un po' le definizioni Minoca, Inoca e insomma, scoprire un po' il Sarchiapone della cardiologia. Grazie.
Grazie per l'invito. Condivido lo schermo così. Vedete le slide?
Benissimo.
Okay. Allora, di nuovo, gentili colleghi, grazie per l'invito, è un onore parlare ai vostri seminari mensili. Ringrazio in particolare il professor Pedrazzini che mi ha voluto qua. E io farei così anche il professor Lawrence Rabber, insomma, è più coinvolto, lo farei in inglese se non ci sono problemi.
Benissimo, va bene, grazie.
Allora, to talk about about Minoca or Inoca, I wanted just to go a few years back in the early 80s about the pioneeristic work of De Wood and later those of John Ambrose, because let's say that all started there in the 80s when both De Wood and later in 88 John Ambrose reported that myocardial infarction appeared to evolve from plaques that on invasive angiography were often non-obstructive before the index event, and the prevalence of non-obstructive coronary artery disease in patients with myocardial infarction was about 5%. So this topic, it's not new. It's now over 40 years that we study Minoca and Inoca, but still it constitutes a hot topic. So what is the prevalence of Minoca? Early trials such as GASTO and then TB trials reported that the prevalence of Minoca was higher in patients, especially patients with unstable angina and in patients with STEMI and with non-STEMI, and was higher in women and in men, with a prevalence in women with unstable angina that reached 30%. These data were are confirmed by contemporary data data with action get with the guidelines registry that confirmed that Minoca it's more frequent in non-STEMI and in women, reaching in women with non-STEMI 15% of the Minoca population. One of the until the early 2000s, it was thought that the Minoca was had a good prognosis. However, in this pooled analysis of TIMI trials done by Raffaele Bugiardini, that was one of the first that showed that patients with Minoca has a prognosis that is not so benign that it was.
Scusi, dottoressa, la interrompiamo, ma noi non vediamo le slide cambiare.
Ah, chiedo scusa, vedete adesso?
Adesso sì, grazie mille, scusi.
Okay, so I was saying that the prevalence of Minoca in early trials, such as Gasto and TIMI, was approximately was higher in patients with unstable angina and in women reaching 30% of the patient population, and these data were confirmed by contemporary data from the Action Get with the Guidelines Registry that showed that in non-STEMI and in women, Minoca constitutes approximately 15% of the patient population. One of the topics that was until the early 2000s was thought that patients with Minoca has a prognosis that was very good, so was not a concern, the prognosis in these patients. However, one of the earliest studies done by Raffaele Bugiardini showed that patients with Minoca has a cumulative risk of death, myocardial infarction, revascularization, unstable angina, stroke, that is at 1 year follow-up was at approximately 2%, so showing a prognosis that was not so benign that it was thought before. And also, it must say that patients with Minoca or with non-obstructive CAD, the prognosis also depend based on the extensive, the severity of the disease. In this study done with a CT scan showed that the hazard ratio for the occurrence of cardiovascular death, myocardial infarction, patients with non-obstructive CAD, of patients with who had an extensive disease that was over 4 segments involved, has a similar rate of cardiovascular here that are in orange and in red, has a similar rate of cardiovascular death or myocardial infarction as those with obstructive CAD, but with less extensive coronary artery disease that were less than 4 segments involved. On the contrary, patients with non-obstructive coronary artery disease with less than 4 segments involved has approximately the same rate of advance that patients with smooth coronary arteries. These data are important because it should be noted that the presence of non-obstructive coronary plaques in coronary artery disease is not normal, and as showed previously by studies by DeWood and Ambrose, atherosclerosis progresses in a nonlinear fashion due to multiple plaque ruptures, and myocardial infarction, especially STEMI, typically occurs in patients with mild and moderate plaques. And these data were also confirmed by a recent study with Swedish Heart Registry that shows that among 340 patients with Minoca who underwent coronary angiography for reinfarction, 47% had developed coronary atherosclerosis during the second myocardial infarction, and 53% had still non-obstructive CAD. So this data reinforce the notion that still non-obstructive plaques deserve an aggressive management therapy. With our group, we sought also to see the 6 differences in modifiable risk factors and severity of coronary artery disease, and we showed that approximately 5% of women and men undergoing angiography had non-obstructive coronary artery disease, that is Minoca. This finding is concordant with prior work, but also confirms that the excess risk of mortality in STEMI in women was restricted only to patients with obstructive coronary artery disease, and we did not find any difference in mortality rates among STEMI patients with Minoca between women and men. And also these data are also concordant with prior studies with the guidelines registry that showed that sex differences in Minoca were confined to patients with non-STEMI, but not those with STEMI. So moving to the guidelines, what is the definition of Minoca? And here I found some differences in the definition, because the 4th definition of myocardial infarction defines Minoca based on the classical criteria of myocardial infarction, type 1 and type 2, that is in the absence of stenosis over 50% in a major epicardial coronary artery demonstrated on coronary angiography, and no clinical overt specific cause for the acute presentation that other than acute myocardial infarction. That is, that non-ischemic causes of myocardial damage, such as myocarditis, for example, are excluded. And the newly released 2025 guidelines on acute coronary syndromes of the American Heart Association and the American College of Cardiology do not give any recommendation or definition for Minoca, and states that should be referred to the 2029 scientific statement of the American Heart Association. This statement refers to the 4th definition of myocardial infarction, and states that Minoca should be reserved for patients in whom there is an ischemic basis for clinical presentation. That is, that patients with clinically overt causes for elevated troponin, such, for example, sepsis, clinically overlooked obstructive coronary artery disease, or clinically subtle non-ischemic mechanism that can mimic myocardial infarction, should be excluded for the definition of Minoca. Nevertheless, the 2023 guidelines for the management of acute coronary syndromes report that Minoca should be considered as an umbrella term that encompasses all coronary and non-coronary pathophysiologies. Well, this, in my opinion, is a definition that could be a little bit misleading, because the treatment, the definitions are based on the underlying pathophysiology, and the underlying pathophysiology guide medical management, acute medical management, but also secondary prevention therapies. In my opinion, the causes of Minoca, based on the definition of the 4th definition of myocardial infarction and that of the American statement from the American Heart Association, are more accurate, and the specific causes are those atherosclerotic causes, such as plaque rupture, erosion, in situ thrombosis, epicardial coronary vasospasm, spontaneous coronary artery dissection, coronary microvascular dysfunction, and supply-demand mismatch. To The identification of the case of Minoca is feasible, and as mentioned previously, has the potential to guide medical therapy for secondary prevention. In the study by Harmony Reynolds that enrolled 300 women with a diagnosis of Minoca, and these women underwent OCT or CMR, a cause was identified in 85% of patients, and showed that approximately 64% of patients, the cause was an atherosclerotic cause, so that had a truly myocardial infarction, and the other patients was identified as having myocarditis, Takotsubo syndrome, of non-ischemic cardiomyopathy, and no cause was identified in the remaining 15% of the patients. It should be noted, however, that none of these patients underwent provocative testing for coronary artery vasospasm, and only 60% of the patients had 3-vessel OCT, which may have led to an underestimation of the true prevalence of plaque disruption. So perhaps in those patients that no cause was identified, some plaque disruption or coronary vasospasm may be were underestimated. On the other hand, it is thought that also patients with Minoca has no risk factor burden. This is not true, because in this study we found that many patients with non-obstructive CAD and Minoca had the burden of conventional risk factors such as hypertension, diabetes, smoking, and hypercholesterolemia were present at a much higher prevalence than commonly believed, with only 8 to 10%, from 8 to 10% of the patients lacking any conventional risk factors. And also we found that the harm of smoking, of diabetes, differs by sex, with women having much more harm as compared with men by smoking and diabetes, and these risk factors also equalized the risk for the development of obstructive coronary artery disease at any age. I wanted to mention this study because one of the predictors, this is an unselected population of Minoca patients. It's a registry study with EMACE registry from the UK that showed that the predictors of death of Minoca, only ACE inhibitors, treatment with ACE inhibitors, reduced mortality as 6 months in Minoca patient. But moving to the management of Minoca patient, again, the diagnosis of the underlying cause of Minoca will enable the appropriate treatment to be initiated based on the final diagnosis, and secondary prevention therapies should be considered for this patient, especially when there is an evidence of atherosclerotic disease, and to control risk factors. So in case of plaque disruption, for example, aspirin, high-intensity statin treatment, beta blockers, ACE inhibitors, or in the presence of coronary artery spasm, calcium channel blockers, or nitrates or nicorandil. And moving to ischemia with non-obstructive coronary artery disease, this syndrome of chest pain and myocardial ischemia with normal or non-obstructive coronary arteries at angiography is common, and it's of practical importance to the general medical audience. Many studies in the last decades have tried to address these topics, but until now, only one thing is clear, that these patients constitute approximately 50 to 60% of patients with chronic coronary syndrome. And again, the prognosis here is not such favorable as was believed in the early 90s. Yet we all remain confused by patients who refer to a history of aortic angina or angina-like chest pain, who coronary angiograms do not show evidence of atherosclerotic plaques. And the recent 2024 ESC guidelines dedicated so much on the INOCA or ANOCA, and the cause may be the transient or sustained impairments in the supply-demand of myocardial perfusion. And the new guidelines define two major endotypes, that is microvascular angina or epicardial vasospastic angina. However, as shown in this figure that is of the guidelines, the true prevalence of INOCA, although it's not it's unknown, it depends also on the testing or invasive testing that was used to diagnose the syndrome, and it can range from 30 to 50% in, for example, in tests such as stress test or ECG stress test to 80% in those in invasive coronary vasomotor function testing. And what is the prevalence of INOCA? In a recent systematic review or meta-analysis of selected cohorts, it was reported that the microvascular angina was the prevalence about 41%, and in vasospastic angina 40%. However, I wanted to remind these old studies, the CAS study, coronary artery surgery study, because even it is an old study, it was unselected cohort of patients that shows that INOCA was present in 50% of women and 17% of men. And among women with angina in the YE study, 57% had a non-obstructive coronary artery disease, with 34% of patients with not detectable coronary atherosclerosis. Well, however, I do not believe that the classification that the guidelines into major endotypes is too simplistic, because the study by Lee and colleague showed that there are multiple causes for INOCA, and this is not a short list. In this study, the majority of patients with angina, in the absence of obstructive CAD, had occult coronary abnormalities. In this comprehensive invasive assessment that included fractional flow reserve, but IVUS, acetylcholine testing, index of microvascular resistance, concealed diffuse obstructive disease defined by FFR was the least frequent. That was only the 5% of the cases, while endothelial dysfunction, microvascular dysfunction, and myocardial bridging were detected in about 3/4 of these patients, enhancing the concept also of multiple mechanisms for angina in the same patient, because about 50% of the patients had more than one abnormality. And moving to endothelial dysfunction, this is some kind of important in the setting of normal coronary artery disease or angina, because this study showed that among women with angina and normal coronary artery disease that underwent acetylcholine testing at the during the first coronary angiogram, those with positive acetylcholine testing developed overt atherosclerosis and obstructive coronary artery disease during the 10 years follow-up. But on the other hand, none of the patients that were acetylcholine negative developed coronary atherosclerosis. So this concept of the dysfunction of the endothelium-dependent vasodilation that is strictly related to worse prognosis, and it is important because follows that patients who do have severe endothelial dysfunction may benefit from intensive preventive treatment and follow-up. And the recent guidelines also in their diagnostic algorithm for Minoca, introduce also the concept of endothelium independent and endothelium dependent testing with low dose acetylcholine to test vasodilation, but also vasoconstriction. And introduce also the concept to sequential testing with functional imaging. This is kind of important because the discussion about which modality to use as a first-line test has been heavily focused on the detection of obstructive stenosis, neglecting the high prevalence of non-obstructive coronary artery disease and Minoca, especially in women. So the rationale behind what test to choose as a first line, in my opinion, should be that in order to assess not only the anatomical severity, but especially the functional consequences of coronary disease, whether obstructive or not. The guidelines put an emphasis on the PET-CT that should be more frequently used. However, this is kind of difficult because the availability of PET-CT it's not so frequent. So the sequential testing, for example, with CT scan or other tests should be preferred. Moving to acetylcholine, it should be said that many studies have showed that acetylcholine is sex-dependent, with women showing responding to low doses of acetylcholine as compared to men. And this is important considering that normal coronary endothelium releases vasodilates in response to low-dose acetylcholine, resulting in vasodilation, and it results that women have more severe endothelial dysfunction as compared with men. As treatment strategies in patients with Minoca, again, guidelines give emphasis to treat according to the underlying cause. So in case of abnormal vasodilation, beta blockers, calcium channel blockers, ranolazine, or in patients with endothelial dysfunction, ACE inhibitors and statins, and also in case of vasospasm, calcium channel blockers, nitrates, or nicoradil. Well, this is an algorithm of management that is modified from prior work of Bugiardini and Noel Merz. And of course, first in patients with chest pain, we should stratify if the symptoms are stable or not. If not stable, should undergo coronary angiography. And in case of normal angiography or non-obstructive coronary artery disease, coronary vascular function studies and physiological studies can be considered, and in case of abnormal results, aggressive medical symptoms management with aspirin, beta blockers, statin, ACE inhibitors, and calcium antagonists with vasospasm should be initiated. In case of stable symptoms, functional imaging test should be the priority, and in case of abnormal or abnormal myocardial function evaluation, other causes should be excluded. Other causes of chest pain should be excluded. So in conclusion, non-obstructive CAD, Minoca and Minoca continues to pose a mystery, affect a significant number of patients, especially women, and pose serious burden to health services. We still do not have evidence-based guidelines for treating non-obstructive CAD, but we still can do something. And of course, aggressive secondary prevention treatment with aspirin, ACE inhibitors, beta blockers, and statins should be initiated in the patient. Thank you very much.
Thank you, grazie mille per la presentazione. E la discussione adesso è aperta, se ci sono domande. So tu Marco, se hai qualche commento.
Dottoressa, facciamo la discussione in italiano per non inibire nessuno, but any moment you want us to translate, Lawrence, you let us know. Lei, dottoressa, è un'esperta di sex medicine, argomento controverso, difficile, di moda, però molto spesso affrontato in maniera superficiale. Quindi io vorrei da lei il suo know-how su, uno, il razionale biologico per cui Minoca è più frequente nelle donne, e qualche considerazione sul perché dovrebbe avere un impatto prognostico diverso in base al gender. Questo io faccio fatica a capirlo. Non è semplicemente un bias statistico, epidemiologico, un lack of power, piuttosto che una vera differente prognosi nei pazienti con o senza, con maschio o femmine. Qual è la sua opinione in merito?
Come dimostrato prima, per quanto riguarda le donne, è stato dimostrato nei vari studi che la disfunzione endoteliale nelle donne è più severa rispetto a quella degli uomini, e la disfunzione endoteliale a sua volta dipende anche dai fattori di rischio, quindi spesso le donne, soprattutto dopo una certa età, hanno la prevalenza dei fattori di rischio è maggiore rispetto a quello degli uomini. E questo spesso forse dipende anche dal fatto che molte terapie cardioprotettive negli uomini vengono iniziate prima che nelle donne, che vengono iniziate a una età più, diciamo, più avanzata, dopo i 60 anni di età di solito. Per quanto riguarda, e questo per quanto riguarda il Minoca, per quanto riguarda il Minoca nello STEMI, ma anche per quanto riguarda lo STEMI con stenosi insomma ostruttive, eh, eh, si è dimostrato non solo nei nostri studi, ma anche in altri studi che con le terapie contemporanee e la revascolarizzazione, come nel caso dell'occlusione trombotica dello STEMI, non ci sono differenze fra uomini e donne. Le differenze di solito avvengono nel non STEMI. Questo è un po', diciamo, dipende anche dalla maggiore eterogeneità di questa tipologia di popolazione, e molto probabilmente anche delle terapie che vengono iniziate, perché le donne sono di solito sottotrattate soprattutto con terapie di prevenzione secondaria rispetto agli uomini.
Grazie mille, ci sono altre domande, commenti? Io ho solo una curiosità invece, visto che appunto è un argomento molto particolare questo della malattia, della patologia dell'ischemia miocardica senza lesioni angiograficamente evidenti, eccetera. C'è stato nel tempo un aumento della prevalenza di questo tipo di, chiamiamolo patologia o situazione emodinamica vascolare? Oppure qualcosa che è rimasto stabile, ovvero sia anche gli stili di vita, lo stress possono aver contribuito, possono contribuire all'evoluzione di questo di questa patologia?
Beh, sicuramente i stili di vita, ci sono tanti studi sul myocardial ischemia induced, food mental stress induced myocardial ischemia, che hanno dimostrato che c'è una correlazione molto importante fra lo stress o uno stile di vita molto stressante e il Minoca e l'Inoca. Questo sicuramente, e sicuramente la prevalenza soprattutto dell'Inoca è in aumento, ma perché è in aumento? Perché la diagnosi con le strumentazioni diagnostiche attuali, sia non invasive che invasive, fa sì che sono migliorate, che è aumentata anche la prevalenza, perché è aumentata la diagnosi. Per quanto riguarda il Minoca, il trend negli anni è rimasto abbastanza stabile, con una maggiore prevalenza di incidenza di Minoca nei non stemi e nelle donne e nell'angina instabile, ovviamente.
Grazie mille, dottoressa. Allora, con questo la ringraziamo nuovamente per
Grazie a
la sua
voi.
partecipazione, seppur virtuale, e speriamo di poterla accogliere la prossima volta in presenza. Grazie mille, arrivederci.
Grazie a voi, arrivederci.
Allora, proseguiamo con il nostro caso interno, che preparerà il stage per il nostro guest speaker, che è Lorenz, che vado a presentare poco più tardi. Il presentatore è il dottor Milzi, che ci presenterà un caso di Minoca, se non sbaglio. Grazie,
Sì.
Andrea.
Grazie Marco per la presentazione. Ho il piacere di presentarvi, come detto, un caso di Minoca, quindi un Sarchiapone a chilometro zero, se vogliamo. Quindi si tratta di un uomo di 55 anni con un profilo di rischio abbastanza importante, un'ipertensione, una dislipidemia, una storia familiare di infarto miocardico. Il paziente è in realtà già noto da noi, nel dicembre del 23 ha fatto una PCI sulla discendente anteriore per una sintomatologia di angor che insorgeva abbastanza episodicamente, non realmente riproducibile allo sforzo, e è stato bene per qualche mese. Poi già da qualche mese dopo, già in realtà da 4-5 mesi prima della sua presentazione, ha accusato episodi recidivanti di angina, di dolore toracico, che non si presentavano sotto lo sforzo e a volte avvenivano o a riposo oppure sotto un blando stress emotivo. Ha anche una storia di Raynaud sotto una terapia. Grazie. Paziente che ha una sintomatologia abbastanza tipica, quindi un'angina irradiata al giugulo, una nausea, e questi sintomi gli sono nati a riposo, e il trigger per questi sintomi era rappresentato da dei pensieri negativi. Il paziente aveva avuto qualche mese prima addirittura un lutto da cui non si era completamente ripreso. Niente dispnea, niente sincope. ECG normale, una troponina moderatamente elevata, quindi da 12 a 25 fino a 55 a 6 ore. Un'ecografia completamente normale. Quindi si pone l'indicazione all'angiografia coronarica. Questo è il sistema destro, che possiamo vedere essere sostanzialmente del tutto normale, salvo qualche minima irregolarità al tratto medio. E qui a sinistra vediamo una circonflessa, anch'essa sostanzialmente normale, qui in 2 proiezioni, e vediamo il Riva, che qui è stato trattato con uno stent assolutamente pervio, senza alcun tipo di ristenosi, al limite qualche irregolarità di parete qui, motivo per cui adesso abbiamo una diagnosi di Minoca, quindi un infarto miocardico senza un'ostruzione coronarica. Cosa fare? Questo è l'algoritmo che viene proposto dal position paper degli APCI del 2022, che quindi ci obbliga, tra virgolette, a fare una valutazione della cinetica, ma l'avevamo già fatta in realtà con l'ecografia, e andare poi a cercare ulteriori cause. La prima cosa che abbiamo fatto in questo caso è un test all'acetilcolina, che si è dimostrato francamente patologico. Ad un dosaggio già molto basso, 50 microgrammi, si slatentizza questo spasmo importantissimo della discendente anteriore, che poi si revertiva completamente dopo la somministrazione di nitrati. A completamento dell'indagine andavamo poi a fare un'indagine fisiologica con una misurazione della funzionalità del microcircolo, sostanzialmente andando a riportare qui un FFR di 0,88, quindi un'assenza confermata non solo all'angiografia ma anche alla valutazione funzionale di una ostruzione significativa, e soprattutto confermiamo una dilatazione del circolo microvascolare con una CFR ampiamente sopra il valore soglia di 2,5 e con delle resistenze molto basse, quindi al di sotto del 25. Quindi questo è un quadro che poi abbiamo completato anche con un IBUS che non vi ho riportato essendo perfettamente normale, in cui sostanzialmente abbiamo esaminato a 360 gradi quelle che potevano essere le cause del nostro Minoca, e come causa abbiamo chiaramente evidenziato questo importantissimo spasmo. Il paziente ha ricevuto una terapia con un calcio antagonista, è stato messo sotto verapamil, e all'ultimo follow-up che ha fatto ambulatorialmente qualche giorno fa stava bene, non aveva più riportato altri episodi di Angor. Grazie.
Grazie Andrea, se ci sono domande, burning question come si dice per Andrea, le adressiamo subito, se no questo caso è perfetto per darci là per introdurre il nostro guest speaker, che è il professor Lorenz Reber, Corro Labor Writer, responsabile del Corro Labor dell'Inselspital di Berna e anche extraordinary professor a Berna. Lorenz è un esperto di imaging, ha conseguito il suo PhD a Rotterdam, al Thorax Center, dove penso abbia preso l'amore per l'imaging e l'OCT in particolare, che l'ha portato a essere sicuramente un opinion leader in questo ambito, e accogliere, tra l'altro, se non altro una volta sicuro, anche i ticinesi a Berna per insegnarci l'uso dell'OCT. So we switch into English. Lauren, thank you so much for coming, for being a part of the Pomeriggi del Cardiocentro. Your specific knowledge on imaging, it's very key for us to understand what can we improve in our diagnostic algorithm. And of course, we are very happy to hear from you your experience and your teachings in this mystery box, which is Minoca. Thank you so much.
Thank you so much, Marco, Enrico, for the invite. And I hope my talk will be illustrative for you for daily clinical practice. Minoca is something you encounter not on a daily, but maybe on a bi-weekly basis. So it's important to know. And, you know, you have patients in front of you that come, suffer. I call those patients really Minoca that really present like an infarction. I don't like to categorize a type 2 MI with a hemoglobin of 80 and the tachycardic AFib as Minoca. That makes no sense. But you have a patient in front of you who has a troponin of 500, who really was scared, and you cannot explain to him why this happened. This is, for us, pragmatically a Minoca, and this is what I want to talk about today. So, for me, and the prior speaker has alluded to the problem of defining it. So what does the word mean, actually, myocardial infarction with non-obstructive coronary artery disease? And this is a working diagnosis, of an unclear MI, that an MI with an MI-like presentation, because you know from beforehand that some proportion of these patients will have myocarditis or something not at all related to the coronaries. That's why it is a MI-like syndrome that presents to you, and you know from the beginning that you have to invest quite some thoughts and maybe also further technical evaluation to come to a conclusion. And only after this process of multiple testing, you may end up with a true diagnosis of myocardial infarction with non-obstructive coronaries, maybe in 40–50%, and the rest is maybe myocarditis, Takotsubo, you name it. And then you need to change the report. I mean, first, when the patient may be leaving the cath lab, he has a working diagnosis of Minoca. He undergoes then a battery of tests, and then you have to revise the diagnosis. I think that's important. This has already been said. The frequency is about 5 to 10%, a little bit more in female. And if we compare the prognostic impact, Minoca versus no MI patients, of course, they have a worse prognosis. But if you compare with classical MI patient, the prognosis is better. If you take this study that has done MRI in 250 patients, and compare the MACE rate, you see that Minoca, the blue line, is approximately, so the true Minoca confirmed by MRI, the blue bar here, is approximately the same as with myocarditis. They had they found a typically large proportion of non-ischemic cardiomyopathy, for example, Takotsubo, but here only 30%. And they also considered dilative cardiomyopathy, which I don't really understand, because if a patient is presenting with a dilative cardiomyopathy and a troponin of 30, it is certainly not a Minoca patient. So it's a bit strange, but just to give you a flavor of the prognosis of a true Minoca patient is about the same as one that has the final diagnosis of a myocarditis. The treatment, I mean, there was one large Swedish study that looked at the treatment and potential impact on outcome, but this is a difficult study because it's a mixed bag. And it's just interesting to see that 90% get statins at discharge, about 60% ACE inhibitor or AT blockers, and 80% beta blockers. So this is the list of causes, but I don't want to be boring. I just go through the algorithm how we probably should approach these patients with myocardial infarction-like presentation without, at the first glance, obstructive CAD. So the first thing is excludes those classical type 2 patients. If a patient has normal coronary and presents with an AFib of 140, that's not a Minoca. If a patient has a hemoglobin of 60, that's not a Minoca. If a patient has a severe renal failure, is not a Minoca, etc. This should be excluded. And to me, you know, I really like to include in the Minoca working diagnosis patients that really have typical chest pain, that have a good troponin, that have a true dynamic of the troponin, going up at least to 250 probably, because otherwise we won't see anything in the MRI. And then the first step is, and that's our responsibility in the cath lab, to do a proper angio. This is extremely important, extremely important. We need a high quality angio. This is very, very important, and I will show you why. So this is a good angio, 6 French catheter. Of course, usually you do 5 French catheter, but if it's inconclusive, I have a low threshold to upgrade to a 6 French catheter so that I really get a good flow in the coronaries, multiple projections. So what is not good is too much overlay. What is not good is insufficient injection because there's not a proper intubation, and you really are not able to evaluate the periphery of the coronary arteries because you need to be able to appreciate the details in these Minoca patients. So these are 2 examples that are not good. So what you also need to understand is the basics of anatomy, of course, because unfortunately, and you please make up your mind here, this was a recent case in our cath lab during the night, presented with a classical MI, chest pain 6 out of 10, troponin 700. And then the operator actually suspected an LAD problem. He used a 6 French, a wire. And what is the problem here? Of course, you realize that there's a first dominant diagonal branch, but then there's a vascular zone here. There's no diagonal 2 or 3. And this really should create suspicion that there is an osteal occlusion. And what you also, so you need anatomical knowledge. What you also need to do is to film in a prolonged manner so that you may be able to appreciate collateral filling of the occluded vessel. So here, this is pretty clear. This is an occluded second diagonal branch, which was filled by by injecting enough contrast and by filming long enough so that you would see the collateral filling of this osteal occlusion. What you could also do here, of course, is imaging to see the occluded side branch. Has not been done. This happens in daily clinic practice. Was not a good management because what finally happened is that the diagnosis came only by the MRI with a transmural lateral infarction. That's how it should not go. You really need to be a Sherlock Holmes. Look at that angio. Sometimes Minoca patients really have minute findings, and you're able to see them if you are patient enough and really do the angios in multiple projections with high quality, so that you discover, for example, this very peripheral circ embolization that is the cause of the Minoca, and after aspiration it was opened again. So this proves how important it is to use the angio as a gold standard tool to decipher Minoca cases. And of course, the levography is extremely important. I mean, this is a classical Takotsubo. Everyone would agree. You already see that in the echo, but of course, the patient needs a coronary angiography. But if the LAD is open, it's pretty clear that this is a Takotsubo. But the levography is also extremely important to depict regional wall motion abnormalities, because if you have a regional wall motion or abnormality or an ECG change, you know in which vessel you need to focus your attention. No, because that's what I would call the suspected infarct vessel. So that's the reason why you should do levography, to define the suspected infarct vessel, either by angio, you see a haziness, or by regional wall motion abnormalities, or of course by abnormalities in the ECG. And if you define a suspected infarct vessel, the next step is a detailed investigation of this vessel. Now, the next question is there thrombus? Is there lumen disintegrity, or is there an ostial side branch occlusion like in the example that I have shown? This can be done as a standard approach. So you look, and for that you have to use intravascular imaging, preferably OCT, because this is a high resolution method. You can easily depict erosions. That's mostly based on a fibrous plaque that undergoes endothelial denudation and then thrombus formation, a plaque rupture with typically not an occlusive thrombus, but no thrombus or just a little thrombus, or mostly thrombus that has been embolized. Or if you find little thrombus in the absence of a plaque, like here, it's an embolism, because a thrombus can only formate based on a local plaque event otherwise, and if there is no plaque, it must be a thrombus or an ostial occlusion. These are the scenarios that you may discover by routine screening of the infarct-related vessel. I would never do 3-vessel imaging. That's nonsense. You need to have a clinical suspicion. Otherwise, it would be highly ineffective and really not advisable. So there are 2 methods how we can look into the coronary artery with higher precision than angio. This is the light-based optical coherence tomography with a resolution of 10 micrometer. It can be regarded as a microscope that we have in our hands, or the intravascular ultrasound with a resolution that is 80 to 150 micrometer. This is an example of a 50 megahertz ultrasound. And you can see, because Minoca patients per definition have minute findings, because otherwise you would see them easily by angiography, the findings are small, and therefore you need a high resolution technique. And that's why I believe OCT is superior, because, if you look at this image here, this IVUS, it's quite tough to really see that there is a little thrombus here on top of this plaque. Of course, you see that there is a plaque, but you don't necessarily see the thrombus, but here you see it easily. This small plaque rupture can probably be appreciated, but needs some experience. With the intramural hematoma, it's a bit easier. Both techniques are probably equal for the evaluation. So this is an example. Patient with only modest cardiovascular risk factor, a little bit of nicotine abusus, 30 minutes chest pain, then ventricular fibrillation in presence of the ambulance, luckily successful electroconversion. The ECG was normal, and he has a peak TNT of 950, and the LV angiography was completely normal. This is the angio. He had a little haziness in the LAD. So we do have angiographic suspicion of a suspected infarct vessel. We need to clarify that with high resolution imaging. And what we find is, first of all, thrombus. Second, a thrombus in context of an atherosclerotic plaque. You can screen the entire vessel. There's no plaque at all only there were the thrombosis, there was a plaque and no plaque disruption. So this is an erosion, a classical, the most frequent reason for MI in young patients, females and males. A classical example of an erosion. This has been treated conservatively with potent TAP and, of course, high-intensity statin therapy. And the most important, stop smoking. This is another case where actually the anatomical picture suggested that there is a avascular zone, and he had regional wall motion abnormalities inferior posterior. We did an imaging and saw that there is a large side branch that is occluded here, and then subsequently could open it with a nice result. Of course, this is a classical atherosclerotic MI, and this needs to be relabeled because it's not Minoca, it was an occlusion, a complete occlusion. So if the answer to this question is no, we have to ask ourselves, is there maybe a prolonged spasm present? That's very rare. I have once had a patient who took a new migraine medication who presented with a prolonged spasm. That's very rare. But what is a bit more frequent and probably also answers the question you had, Marco, regarding the higher risk of Minoca in female, that's SCAD. SCAD is clearly underdiagnosed, and mainly SCAD type 2. These are the SCAD patients that just bleed beyond the media and don't have any visible dissection in the coronary angiography. They have smooth stenosis. It's quite challenging to diagnose. In the imaging, very easy. So an example, 34 years old male with a classical enzyme constellation, severe chest pain, and as you will see here, clearly an LAD issue. This was the angiography on the right side. High quality angio is important, as said, and this is the angio of the LAD. Very clear MI. The ECG points to the LAD. By the algorithm, we need to image the LAD. That's very clear. The very, very experienced operators may suggest that there is something, potentially something going on here. There's like a smooth stenosis, quite long. And if you look inside, you will see there's a huge hematoma. Here, the probe is placed here. That's an OCT. And you see here the hematoma that is extending until the mid-LAD. This is the hematoma here with the shrumply, it compresses the lumen. That's why the lumen looks shrumply. And if we summarize, the key image is this here. This is the lumen. And here, actually, you see the media, and there is a mass, a homogeneous mass that is of intermediate light intensity that is compressing the lumen. This is why it looks shrumply. And this can only be a hematoma. This is a classical SCAD type 2. In that case, the patient had no longer chest pain after nitro administration. This was treated conservatively. I mean, if the patient is not presenting with ongoing ischemia and with STEMI, this should be treated conservatively. If you take the patient back in the cath lab after 1 or 2 months, the hematoma is completely resolved, does not need a stent. So if this is all negative, you should rethink, could it be a pulmonary embolism? Could it be an aortic dissection? You can easily do that. You can do a pulmonary angiography or an aortography in the cath lab to exclude this dangerous potential differential diagnosis. If it's not the case, you should probably consider a spasm test. In Switzerland, I don't know whether you have acetylcholine available. We don't have it. I use from obstetric the ergonovin, 100 microgram intracoronary bolus. And if you discover a spasm, that might be the explanation, and otherwise you have to go to a non-invasive evaluation. I have a very nice case, recent case with me here for you. It's a female, 45 years old, classical chest pain, severe classical chest pain. She presents with an ECG that is plus minus rather normal, but a clear dynamic of the troponin. As you can see, high LDL. The troponin was 400 at the time point of presentation, and she had no longer chest pain after multiple dosages of nitro. The levography, maybe a little bit hypokinesia here, anterobasal, and maybe a tiny bit of less movement in the septum, potentially. I was not very certain. Then the right side was completely normal, smooth coronaries, no evidence of atherosclerosis. And then the left side, I did multiple shots, really multiple planes, but really nothing that looked strange. Particularly all the septal, there was a huge septal network. It was all there, no osteal occlusion. It was really a lot of septals. The diagonals were there, no evidence of scut, no smooth long stenosis as before. So this is the time point where you should do an OCT, as we learned. And here she has a bit of atherosclerosis. The first question is there thrombus? There was no thrombus. Second question, is there lumen disintegrity? There was no lumen disintegrity. There was no scut. There was just, in summary, a fibrous plaque. Nothing else. A focal fibrous plaque in the proximal LAD, co-localized with the septal branch. So now it's time for spasm test according to the algorithm. We gave 100 microgram of ergonovine, and this happened. This is the baseline. Baseline, focus on this part here. And this is, there's not much spasm in the LAD, but can anyone appreciate what happens? Can you run again the baseline? Focus on this part here. Maybe you have to go back go back with the slide once, and then if it's not loading, you just go back once with the slide, the entire slide, or I can do it as well. Wait, so let's run it again. So focus on this part here and compare it with the, yeah. Maybe I try again. Wait, I go back again. Would be nice if it runs again. Wait, let's try like this once again. No, now it does not want to run. It's stuck now. Now it's completely stuck. That was too much. Let's go back to. It was too much, but I have. Okay, so. And as said, Minoca is really Sherlock Holmes. Any suggestion? Septal. Yeah, septal disappeared. Septal disappeared. So if we now look closer, what happens inside is very interesting. The media is spastic, and this plaque is really now becoming obstructive. You don't appreciate that much by angiography, but this was an OCT during the spasm. During the spasm, it's really almost subtotal, also for the LAD. But you just see in the angio, you just see a haziness. But the septal is squeezed. The septal is squeezed. So if we summarize, this is baseline. This is the septal branch, huge septal branch, and upon administration of ergonovine, it creates a huge spasm. The lumen gets bumpy, as you see here, and the septal branch is occluded, which creates the myocardial infarction in that case. And under a calcium antagonist, it did not occur again. If that would occur again, I would just stent it, because there is a clear target for mechanical treatment, because most spasm occur at the position of a focal plaque. Of course, if it's diffuse, it will not be a good idea to stent, but if it's focal, like in this lady, you can do it. And this was the MRI, just not to fool you. This was a clear septal infarction. It was transmural in the septum. So if all this is negative, we're still going back to the algorithm. You have to move forward with a non-invasive evaluation. And here the question is, do we find a scar, edema and or scar, subendocardial or transmural, which confirms the true diagnosis of Minoca, which you were not able to unravel so far, or do you find a scar or edema, epicardial or mid-ventricular or at the insertion points, which speaks for myocarditis, perimyocarditis, or do you find a kind of cardiomyopathies, which is probably much more rare? So the classical situation in the MRI would be in the late, like shown here, a subendocardial or transmural scar with edema in the TIRM sequence, in the T1 weighted inversion recovery magnitude imaging sequence, or as compared to the myocarditis, where you see in the late gadolinium enhancement as here epicardial or mid-wall, or at the insertion points here epicardial, a scar and edema in the TIRM sequence. The other finding that is that can also be frequent is Takotsubo, where there's no late gadolinium enhancement, but in the TIRM sequence you find apical and mid-wall edema, and then perimyocarditis, of course, can be together with the classical findings of a pericarditis, but if they show an enzyme increase, they also have a bit myocarditis in the epicardial region. So MRI is the way to go. That's very clear. And it should actually not be delayed too much, because you probably will find more in the early phase. This was a study that compared 300 Minoca patients. Half of them received the MRI early and half of them late. And you see the normal findings were much more frequent in the late phase. So probably you miss some. Of course, that's also a bias, because the severe one will receive the MRI earlier. That's clear. But still, I think it would be good to have the option to get the MRI within a week or so, or still during the index hospitalization. And this study was already mentioned. It was published. It's one of the rare, well-executed Minoca studies published in Circulation, where they applied an algorithm using OCT and MRI, and they really were able to identify the causes in 85% of cases when they combine routine imaging invasively and non-invasively with MRI. So this is a patient to underscore the value of non-invasive imaging. A young patient, of course, this young patient has a pretest probability of atherosclerotic MI equals 0. If he has not a genetic mutation or whatsoever, he presents nevertheless with classical chest pain, very high intensity, a classical evolution of enzymes and ST elevations in the lateral and anterior leads. In the levography, there is a bit of hypokinesia inferior and posterolateral, a tiny bit. You can have a suspicion here. And then the angio that was nevertheless done is like this. We had a little bit doubt on the posterolateral branch. Was not completely normal here, so that we evaluated it. I was actually not sure whether there could be a scut there. The left side was completely normal. So we run an OCT just because we had this suspicion, but as you see, and as expected, I mean, this was a completely healthy vessel and absolutely no evidence of scut. So we moved forward with an MRI, which showed a linear late gadolinium enhancement at the lateral wall, lococlassical for myocarditis in the epicardial part, which confirms, of course, the presence of myocarditis. And you see, we also don't have MRI available always within the first week. This was done only 1 month later. So if you get back the report of the MRI, and the radiologist or the cardiologist who is performing MRI writes in the report that this was a true MI, you have to go back to review the angio again, maybe to perform a spasm test, if not yet done. Really ask yourself, did I miss an osteal side branch occlusion? And also potentially then search for an embolic cause, because the phenomenon of an embolic occlusion, distal occlusion, might also apply to your situation. And then probably it's worth to do a TOE to exclude LA thrombus and also to search for AFib, to exclude ASD or PFO, or of course vegetations or prosthesis degeneration if the patient has a heart valve prosthesis or a tumor or aortic thrombus. I have found 2 females with anemia that had an aortic thrombus as origin of Minoca. And an LV thrombus, of course, that should be detected before already. And then, of course, you should also search for a coagulopathy. And here the most relevant it would probably the antiphospholipid syndrome. But I have only 1 patient in mind in the last 10 years that really had a Minoca due to antiphospholipid syndrome. So in conclusion, Minoca is a problem that occurs about in 5 to maximum 10% of patients, mainly the young ones, a bit more frequent in females, I believe due to SCAD type 2, is a working diagnosis, really a 2-step approach. You have a working diagnosis, then you have to go through a certain algorithm as presented, and then to re-evaluate the situation and to label the disease the patient has. Frequently, of course, most frequently atherosclerosis, SCAD, spasm, embolism, myocarditis, or cardiomyopathies, the predominant one, Takotsubo. High quality angio and intracoronary imaging is essential in combination with MRI, and with that you should be able to unravel, let's say, 80% of cases. Maybe 10 to 20 still remain unclear, which is very interesting, I believe, these cases that remain completely unclear, which you cannot resolve. And finally, if that is the case, you can also reassure the patient that the outcome will be better than after a classical MI. With that, I thank you for your attention, and I hope it was illustrative for the topic.
Thank you very much, Lawrence. Brilliant. Extremely practice-oriented, extremely clear. So we are really very thankful for this presentation, which of course opens for discussion and questions. There is already one. Wonderful. Marco is very critical, so I'm sure I will ask a very important question to you, Lawrence. Be prepared.
Thank you very much for the nice presentation. I'm not so critical. It was just a small curiosity. You said in the presentation that it's frequent that vasospasm occurs in the same region where there's a plaque. My question is, do we know if it's the plaque that it's causing vasospasm or the vasospasm that it's causing the plaque?
Yeah, that's a good. I have told you. I told you. I knew it. That's a good question, and I don't know the answer actually. I cannot tell you how but I would say that these patients usually present they have a history of symptoms which is usually very short, which would speak for a plaque being the first, the causative problem in these patients. Because these patients that I have in mind, like I have like a collection of 20 patients, they all presented with chest pain during the last maybe weeks maximum, and they all had focal plaques. So I believe the plaque is a precondition for spasm in European. It's probably, I'm aware of Asian data where they have much more frequent spasm in the absence of plaques. The only exception to that I am aware of, I'm not very much knowledgeable about the literature here, but the only spasm I'm aware of is a toxic spasm after chemotherapy. This I have seen multiple times, or of course drug abuse that can occur. But in the absence of any toxic substance, I have never seen a spasm in the European in the absence of a plaque, and I believe plaque is the precondition.
Thank you.
So thank you, Lawrence. Very brilliant, clear talk. Thank you very much. I have 2 questions or observation. First is one, you perform every time the vasospasm. Let's say the vasospasm test is positive. Do you also perform the functional test for microvascular dysfunction or endothelial dysfunction? Because in the not Minoca but Inoca, you have to perform both. And the second one is about the calcium antagonist. Which one do you prefer mostly? Or
So the first question is the honest answer is it needs another. So during the night call, it will be challenging to do it. If I have a clear vasospasm, I think this would be enough. Then the situation is clear, and I don't see the added value of doing it. If it's negative, you should add it. But it needs special software. You need to start it. You need a nurse who is able to do it. Is a practical consideration, and then you need to give bolus, and you need to be comfortable in the situation to give this poly and ongoing adenosine. That's a practical consideration. So I hardly ever do it acutely. The second question is I give amlodipine 5 milligram and then go up to 10, and I must say 50% of these spasm patients did not respond, and I have now a collection of like 5 patients that I stented, and then it's done. They are really, I know it's not in the guidelines, but if you have a very focal segment that is diseased and you stented it, the story is closed. It's in my opinion probably the best you can do, and the patient does not need a medication anymore. Of course, needs aspirin. But well, that he needs anyway, because they have atherosclerosis. If they smoke, they should of course stop smoking, but that's also only successful in 50%, as we know. So I can recall a case, and this can be dangerous. I forgot to put it in, and now it comes to my mind. We had a case that presented 3 times in the cath lab, and it was not clear that he had a spasm. He already got an ICD, and then we did a spasm test in the third coronary angiography, and then what happened is the left main closed. So it can really be impressive what happens, and you need to be prepared. As you have seen, we used the 6 French guiding catheter and the wire inside to be ready if the spasm is prolonged and occlusive.
so if I understood you correctly, the first coro is in the emergency. I mean, normal, let's say normal coronary arteries. So the next day, or you wait for the MRI and then you perform the second coronary?
Yeah, it can vary. I mean, and it depends on the operator. I mean, either you do it ad hoc, if you have if you know where the medication is stored, and if it seems practical, or you do the MRI first and you see an MI and you come back and do it. But the best, of course, would be to, as I have shown in this patient, to do it acutely. I think that's not, it's safe, it has been proven to be safe, and it's actually simple, because you just need to make an injection, be ready if there is a complete occlusion, to act accordingly. But I think should be, I mean, it facilitates the downstream diagnostic algorithm substantially if you can make the diagnosis at the first glance, but the reality is that is not done always, and then it's important that you may come back. So if in a situation where it's not done and the MRI comes back with a subendocardial necrosis, then you probably need to consider to bring the patient back and do it again.
Any other comments, questions? Yes, please.
Do you use to perform the acetylcholine test in the left anterior descending coronary as a default strategy on when you think the culprit lesion could be there? And if it is negative, do you perform the same in the other 2 coronaries?
So that's a very good question. I do it in the suspected infarct vessel. I think this is really crucial. You have to have a suspicion, and like in this lady, the suspicion was clearly that there's a problem of the LAD, so I start there. And if you have no suspected infarct vessel, I probably still would start in the LAD, and then I would go to the right side as well to complete the test. That I would do, because usually patients support it relatively well, and that takes 5 minutes more. So you should do that.
So
always start in the vessel where I think the spasm will occur.
In a Minoca case, it's the most frequent case in which you can do the same test in all 3 coronaries if the first is negative? And
the imaging I would not do in 3 vessels. That's really there's no point to do that. I mean, and you know, that's also interesting in this study by Reynolds. She had a 50% atherosclerosis and she listed, for example, healed plaque. I mean, no point. This cannot cause an ACS. There's no point. Or a cavity without thrombus is usually an old plaque rupture. It has nothing to do with an acute event. So there I would be a bit careful in interpreting the findings you see in the OCT. You really need an acute event, and this is hardly ever the case if you're in the absence of thrombus. You might find small amount of thrombus, that's okay. But in the absence of thrombus, it's hard to believe that you have an acute atherosclerotic event. That's really, I would have difficulty in understanding. One mechanism, of course, could be a distal embolization, but still you should see a certain amount of thrombus in the culprit lesion.
Meanwhile, the microphone goes to Marco back again. I make a consideration, and which is more a question than a consideration, but I think in the era of precision medicine, the sequence should be reversed. It cannot be that a non-STEMI patient is waiting maybe a few hours to get into the cath lab. You do your standard cath, you don't find anything, you have to bring the patient to MRI, you have to fight for MRI availability, which is a major issue everywhere, in Bern as well. I remember it here, we have the same problem. And in case you find a true MI, then the patient needs to come back to search for the culprit. Why don't we reverse the sequence? The patient would undergo MRI to begin with, and then comes in the cath lab with the MRI information already present. There is one study showing that there is an important effect of MRI before diagnostic angiogram to reclassify what you would do in the cath lab, including Minoca, but in fact not only limited to Minoca.
Yeah, well, the pragmatic answer here is too infrequent, is logistic consideration, cost consideration, and is too infrequent. So in 90, well, I would say in 80%, you will find a classical MI. So the rate in Switzerland of non-STEMI without findings is like 20%. We know it from the new registry. But in 80%, you will do that without, without changing the downstream treatment. So that's why I would not do that. And I could not imagine that it happens that we get like 3 cardiac MRIs available. And then the cost is also like 900 up to 1,000. The angiography costs is like 1,800. So I'm not sure whether it would be making sense to switch the sequence. Of course, is a provocative suggestion, but I don't think it will happen because still the coronary. I mean, that's also what I find extremely strange about the guidelines. I mean, how can you draw that iceberg? It's sorry. I mean, coronary artery disease is what people kills, and it's very prevalent. And it's the reverse. I mean, Minoca is important, yes, but what kills people is atherosclerotic disease, obstructive atherosclerotic disease, and that's what we have to identify at first and treat it appropriately, and then we can approach Minoca. But please, we need to stay focused.
Now with the tough question for Marco.
No. I mean, if you find like a small peripheral dissection as the cause of this Minoca, then you start antiplatelet therapy, and if so, like single or double antiplatelet therapy?
Dissection or SCAT type 2?
Both. Let's say one and the other case.
So basically, you know, I have difficulty in understanding why I should give DAPT in a hematoma case. So we usually, if the flow is TIMI3, I would always only give aspirin. Of course, if it's subtotal and you have reduced flow, the risk for intraluminal thrombosis formation due to small lumen and stasis is a consideration, and in that case you potentially could give DAPT, but we are very restrictive in giving DAPT in this kind of SCAT patient. There is an RCT now running in Spain. I mean, that will provide a definite answer, and this is what we have to do. We have to randomize patients to understand it better. There is observational data suggesting that you can safely give a single antiplatelet therapy in this patient, and conceptually it probably makes sense. I have to, we have like a collection of 50 SCAD in OCT. I have, in the literature is described thrombus, but personally, my personal experience, I have never seen the single thrombocyte in a SCAD. I don't see it. That's why I believe single antiplatelet therapy is sufficient. But in the literature it's described, but I have never seen an image.
Any other comment or question? So when I welcomed you, Lawrence, I said we are always running late, but if the speakers are great, as you have been, and the moderators also likewise great, we are finishing on time. So with that, I would like to thank you a lot for your participation, for the clarity, for the teachings.
There's an aperitif.
Ringrazio come di consueto i nostri sponsor che ci permettono di fare questo pomeriggio mensilmente. Adesso vi invitiamo tutti all'aperitivo al baricentro. Grazie.